I'm a clinical cardiologist. I've been around this institution for quite a while, and what I wanted to do is sort of focus on the area of research and clinical care that has kept me busy for the last 30 years or so. So I'm interested in coronary atherosclerosis, cholesterol buildups in the arteries to the heart that cause heart attacks. There's lots of kind of heart disease, and I could have spoken about other things, but this is an area that is of great interest to me. And when people think about heart disease, this is the leading cause of heart troubles. So let me tell you a story about two different patients that I have had the pleasure of being involved with over the last number of years. The first occurred in 1982, and you think, gee, you have a good memory, but that's a long time ago. The reason I remember this patient is because I started medical school in the fall of 1982, and my first clinical exposure was going to the emergency room to get exposure to see people. And this was the first visit I went to, and this woman was brought in. I was way over in the corner as the scared medical student, of course. And this was a woman who presented with pain in her chest, but she waited about 12 hours before she came to the emergency room because she didn't think about heart disease. We didn't think about heart disease in women at that time, and she was admitted to the coronary care unit. I went away to my office. Medical students had offices in 1982. It was a cool thing. And I looked up really what the treatment was for this woman. And really at that time, we weren't doing a whole lot of things. Aspirin was standard of care, comfort measures to get rid of the chest pain, and bed rest for long periods of time. And we were starting to think about other treatments, but that was basically what we had at that point. I went back to see this woman 4 days later and was told that in fact she had passed away in the hospital. Sudden cardiac death, heart ruptured, and this was a very common scenario back in 1982. So let's fast forward about 3 decades or so. When I was on call this summer, I was on call at the Foothills Hospital. There was a 55-year-old woman again who presented. She was shopping with her husband at Cross Iron Mills. She had chest pain and some pain in her neck. She got out her iPhone, went to Google, looked up this and decided, oh, this probably isn't good. Her husband phoned 911. The ambulance and the paramedics arrived at Cross Iron Mills. They did an electrocardiogram on the spot, and this ECG showed an evolving ST segment myocardial infarction or a heart attack. The emergency doctor made the call and the diagnosis. The ambulance was diverted to the Foothills Hospital. It didn't go to the Peter Lougheed, which is the closest place. And the interventional cardiology team was called in, those individuals that can open up blocked arteries. And what we have going here is that the artery right there is completely blocked. There was no blood flow into that artery. And the next one for me, they changed catheters. They inserted a very skinny wire down the artery and reestablished flow. There's a balloon with a stent. Stent is inflated on top of a balloon, and then the balloon is deflated. And the next slide for me, please. And there's the artery now completely open. So the blood flow that had been interrupted was now reestablished in this individual. Because she was on the ball and smart and the system was activated, is that within 90 minutes of presenting with her initial onset of chest pain, the artery was open and blood flow was reestablished. So she had almost no damage to her heart muscle. She spent 1 night in the coronary care unit. The next day was up wandering around the ward. We prescribed 2 or 3 medicines for her, as is often the case. And on day 3, she went home. No damage to the heart, back at work in a couple of weeks, and a very different outcome to the individual that we saw before. So a lot has happened in the last 30 or so years. In 1982, the chance of dying in the first month after a heart attack was in the 20% range. And in 2014, that number had decreased into the 5 to 6% range. So a 65% reduction in the chances of you dying from your heart attack over a 30-year period. That really is spectacular. It really is akin to what Paul talked about in an antibiotic era compared to a no antibiotic era. Great advances, all happening because of great research. So there's 70,000 heart attacks per year now still in Canada, 50,000 strokes. And if you look at the Calgary population, about 3,000 people per year in our catchment area will have a myocardial infarction. So that's what 8 or 9 people per day are having a heart attack. And so even though we've reduced the incidence of this happening, it remains a major problem for us. So I like to say is that Calgary is a great place to have a heart attack. Sounds kind of funny. Maybe we should put that in the mayor's logo for Tourism Calgary. But in fact, this is the case. And I'm going to tell you why that is in a minute. So this is just a slide that shows 30-day mortality for an acute myocardial infarction across the 10 provinces. And there's Alberta there. This is in 2011 or so. 10 years ago, the difference between provinces was much greater, but because of knowledge translation of the processes that were put in place here, most provinces do very well. And if you look at the Alberta experience and break it down, is that Calgary and now Calgary and Edmonton have wonderful outcomes in heart attacks. And there's a number of reasons why that's the case. So sure, we have great technology, we have better drugs, we have new devices, and within the Calgary Health Region, we have wonderful staff. We have great nurses and pharmacists and nutritionists and physicians, and the backbone of that is available. But that's available everywhere. Most large centers will have that. But the four things and the key reasons, I think, over the last 20 years in terms of why Calgary has emerged as a great place to have a heart attack are the following. So first, the approach database. In 1995, Merrill Knudsen decided that we need to track our heart attack outcomes much more closely, and he developed an Alberta provincial approach looking at outcomes in cardiovascular disease, and he was able to start this database. The database now is anyone in the province who has a heart attack or comes to the catheterization laboratory is entered into the database. Now has 200,000 different people in it. We produce something that looks like this. This is the caricature of your coronary arteries. Every patient that comes into the hospital gets one of these. They go home with it. Patients tell me that it appears on their fridge or their exercise bike, whatever they're most guilty about not doing. And this is a standard of care. But more importantly, they use the data in the research database to write papers that changes care and changes knowledge. They write about 10 important papers per year because of this database starting, 1995. A few years later is that Dean Trabulsi, one of our interventional colleagues, said, the system for which we deliver care for heart attacks is fairly random. We don't do it in a good way. And so he set up the Stemi pathway, and what that involves is what we heard about before. Patient activates the system. He worked with the paramedics and the emergency room doctors and the cardiologists and the rehab specialists to have a system of care. And so what we were able to do is we were able to take this person and get them into life-saving therapy with an angioplasty where we put a stent in the artery faster than we could before. And our time now, you see 69 minutes written there, that's from point of first contact to the artery being open. Before he did this, our time was about an hour later. And by changing systems of care and cutting an hour off of that time, is that our mortality dropped by 1.5% to 2% just like that. So that was an important advance, and really that was copied all over the country. We were the first to begin that, and then Ottawa, and now this is standard of care. This happened because of great clinical research that was done here. The third thing is one of the complications that we see after heart attacks is an abnormality of the heart rhythm. This is a Holter monitor. It's a tape recording device that measures your heart rate. What you see here is the start of something very bad. Normal heartbeat, normal heartbeat, normal heartbeat, a premature heartbeat that then sets off a fast heart rhythm that causes the heart to not pump blood effectively. Within 6 seconds of this starting, the individual will lose consciousness, and unless that is converted with a defibrillator, is that individual will spiral into a rhythm for which there is no return. So you see here 9 minutes, sudden cardiac death, and all of you will have been touched by this at some point with your family or your friends. Half of people who present with a heart attack, the first event is this: no warning, sudden cardiac death. We weren't able to predict that. We have great electrophysiologists here in Calgary. They've looked at novel pathways to try and identify risk for individuals. Derek Exner is one of our young stars who's done this. He was able to identify an electrical signal that seemed to portend an increased risk. And what he was able to do then is go out and gather a bunch of money and start this study, the REFINE ICD study, where he takes individuals that look like they're at risk, who wouldn't otherwise have been candidates for ICDs, and he's randomizing them to get an ICD or not. This is the largest clinical trial ever undertaken at the University of Calgary, some $40 million. Derek is the lead of this, and this will occur in 150 sites. Great research, great education, leading to patient care. And then finally, at the back end is that once you've had your heart attack, is you've got a lot of risk factors, you've had things that have caused you to get to this point, and we can put a stent in the artery, but unless you correct blood pressure issues, cholesterol, diabetes, lack of exercise, is that you're at increased risk of having this again. So the cardiac rehab program within our department does a wonderful job. Jim Stone, Sandeep Agarwal, and others, and rehabilitation of these patients is very, very important. Over the last 30 years, by doing all of these things, as I've told you, we've been able to take the mortality from coronary heart disease from here, 345 per 100,000, down to about a third of that. Similar great gains in stroke care, and total cardiovascular mortality is decreased. But like Paul said, is that we haven't eliminated cardiovascular disease. It is still a big problem. And if you look here, what we see is that in high-income countries, which Canada is that cardiovascular disease is as important as communicable diseases for the total number of people that die. And we used to think of middle-class and low-income countries as being sort of immune to cardiovascular disease and having more problems with infections, but over the next 20 years or so is what we'll see is that there will be an explosion of coronary heart disease around the world. Doesn't mean that the other things aren't important, but this is going to become a huge problem, and what we need to do in Canada and other places is to be able to help and translate that knowledge. This is an epidemic that is going to be very important. So what does the future of cardiovascular research look like? It would be a bit presumptuous for me to say that I had all the answers, but the challenge that I have for you is this going to be newer, greater, better technology, like has occurred in the last 30 years, or is it going to be a more simplistic approach where we actually try and decrease people having heart disease in the first place? So let's run through that a little bit. So firstly, I'm a clinical researcher. I do clinical-based studies. Dr. Koobs is the quintessential basic scientist extraordinaire who looks at basic mechanisms of disease. We have some individuals within the University of Calgary who study the basic mechanisms of cardiovascular disease, and this is absolutely crucial. Basic science, foundational research is what leads all other research. It drives pharmaceutical development, it drives imaging, it drives everything else. So this is going to be key. What you're looking at here is a coronary artery, and this is a plaque. Here's a cholesterol buildup in the artery, and atherosclerosis is formed by the interaction of cholesterol in your arteries, the lining cell, the endothelium, and inflammatory cells. As Dr. Koobs had explained to you, very important in our diseases as well. So what's happened here is the cholesterol has irritated this plaque. The plaque ruptured and a blood clot formed here. The artery blocked off, just like the woman I showed you, and bad things occurred. This individual had a sudden cardiac death. So basic science will help us to understand why this occurs. And this will occur by looking at the genomics, what's the genetic makeup, by looking at what the genome produces by proteins and metabolomics that we can measure in blood. And there are lots of individuals that collect blood samples, put them into freezers to try and better understand this. It will involve stem cells to rebuild broken hearts where myocardial infarctions have occurred. Cellular biology, pharmacology, development of new drugs. Basic science remains very, very important, and that's why appropriately half or more of the money that we spend on research goes here, and that's absolutely critical for us to understand things. So if I had to guess where that's going to be, it's going to be a combination of a variety of things, but might include stem cell development, might include new pharmacology, etc. Number two is imaging. So what you're looking at here is a rendition of a left ventricle. The main pumping chamber of the heart is taken by an MRI picture. So the Stevenson MR Center here has a great reputation. They take pictures of hearts. About 3,500 people per year will have an MRI, and we can look at the ventricle in great detail. So imaging will allow us to do things that we couldn't even have dreamed of. 30 years ago, we had rudimentary ultrasound to look at the heart. Now we have ultrasound that looks in very great detail. We have MRI with no ionizing radiation and can take very nice pictures. So it will allow us to do good things with respect to diagnosis. But what it will also allow us to do is to plan therapeutic interventions. This is Tanya Dumphy. She's one of the spokespeople for the Libin Cardiovascular Institute. She presented to one of our electrophysiology colleagues a number of years ago, Jorgo van Heusen, with fast heartbeats. She was about a month from delivering. All of a sudden, her heart rate was 200 beats per minute. Didn't think that that was very normal. Came in and she had an unusual rapid heart rhythm that if she wasn't pregnant would have been relatively easy to deal with. It would involve a procedure to interrupt the electrical connection between the upper and lower chamber. But those procedures involve the use of radiation. Not a very good thing when you're pregnant. So using mapping techniques, Dr. Van Heusen did the first of its kind in Canada where he was able to map out where the things would be, and then using biomedical engineering techniques in our catheterization electrophysiology laboratory, he was able to find the area that was causing the problem, apply energy to it, and stop the fast heartbeats with using no radiation at all. Instantly, her heart rhythm returned to normal. The threat to her and her baby was done. She delivered a healthy baby about a month later. Research driving great clinical care within our community. And she's been very grateful, and you could see her on our website in her video. It's very touching. The third thing is devices. So cardiologists, we spend a lot of money. We're enamored by cool techniques and cool things. This is a pacemaker, 1981, a real breakthrough, because before, if you had a slow heart rate, nothing good could occur. We had no way to treat that. There was no medicine to speed up your heart rate, and people died. And in the 1980s, as that pacemakers became available, some of you in the room may have them, and they used to be fairly big. They were hard to put in. Technology, they got smaller and better, and in 2014, there are now pacemakers that are the size of the end of this cap. Okay, this isn't a pacemaker. I wish it was, because they cost about $8,000. But this is the size of the pacemaker can now be inserted into your heart without wires or without having to have the battery pack. You just screw it into the right ventricle, and this is what individuals are looking at. So great engineers working with clinicians to solve a problem. And we have great devices with respect to mechanical hearts to assist people who had no options before, and a variety of other things. So there will certainly be new advances related to biomedical engineering and implanted devices. Monitoring. Most of you in the room probably monitor your cardiovascular system in one way or the other. So hands up people who have a blood pressure machine at home. So lots of people do. I have one too. So that's been available, and it's great for our patients to monitor that, okay? Lots of individuals record their steps with accelerometers or pedometers. I got one on my wrist here, count my steps. Lots of individuals have other devices. There are now apps available for your iPhone where you can download an app, you can put it on your heart, and it will do an ECG tracing for you. So you can now have this app, and on the phone, if somebody's having trouble, you can go over and see what's going on, help things out a lot. We have pacemakers that you used to have to come in to get the pacemaker checked. Now you can hold the pacemaker up to the phone, and it will send in the information that's required. We have people with heart failure where you can inject a very small device into their lungs that measures pressure. So if somebody with heart failure is going to run into trouble, the pressure rises, and we would treat them differently. This device sends information back to a smartphone to the physician or the nurse clinician at the clinic to tell them that Mrs. Jones is going to run into trouble because the pressure in her heart went up. So this is spectacular technology. I found this on the internet. I wish this was my idea, but Qualcomm has a tricorder X Prize. So for those of you that are a little nerdy like me and have watched Star Trek, I was always amazed by Dr. McCoy. Had his tricorder, could run it over the patient, tell him what was going on. Well, they're giving out $10 million in 2016 to whoever invents the best physiological recording tricorder device, and these will monitor simultaneously 10 or more different parameters: heart rate and blood pressure and oxygen saturation and blood chemistry, a variety of different things. So monitoring is a big step, and certainly for our patients with pacemakers and other things, it's a huge advance. Pharmaceuticals. We like to dole out medications, and what this slide shows you, this is Alberta Health data that just came out. So if you get to be over 45, is that this is number of prescriptions per 1,000 people. So if you're 45 to 59, is that 1/3 of the population takes a cardiovascular drug. And if you're 60 to 74, then 60% of you do. And if you're over 74, then fully 80% of people take drugs. And the problem with cardiovascular drugs is once you get on them, you're kind of on them for a long time because they're used to treat blood pressure or cholesterol or diabetes or heart failure or angina or other things. So the drugs that we have now compared to what we had in 1982 when the first woman had a heart attack are absolutely amazing. Now, people don't like to take drugs, and you have that handful that you take with you, but at the end of the day, that's a lot of the reason why things are better. So there's a lot of research going on to develop better, newer, safer medications. The downside of a lot of that is that the new drug that will make things just a little bit better tends to cost about 3 times as much as the old drug, and that'll be a theme that we'll touch on for the last part of the talk. And finally, I think a major advance relates to data. Health systems outcomes data. We have a lot of data that we can capture. We change care by mapping out what works and what doesn't work. And this is just an example of data from the Canadian Institute of Health Research. This is the number of myocardial infarctions per 1,000 patients across the province. And what you can see here is that in Alberta, about 200 people per 100,000 will present each year with a heart attack. That's 0.2%. So not only are we good at having a decrease in mortality with heart attacks, is that Albertans tend to have less heart attacks than other places. So we have access to data, and it really is by utilizing this data that we can create changes in the way we deliver care. So there's a lot of things we can do. We can do fancy imaging of your heart. We can do genomic testing. We can measure a variety of things. But just because we can do it, should we do it? And the reason that we talk about that is that because healthcare has become very expensive, and cardiologists are as expensive as anybody else. So this is the sustainability concern. This is the economic loss in the developing world over the next number of years. It's in the trillions of dollars. So we invest money to try and decrease that. So if you look at Alberta data, is that if you look at the amount of money that's spent by Alberta Health per year, is what you can see here is that cardiovascular disease and stroke, we spend about $375 million per year. And if you add diabetes to that, because they're related, then we're at the top of the heap above mental health and addictions, around $500 million. So years ago is that we used to spend a fair amount of money, but the total amount compared to our gross national product was around 6 or 7%, and now it's about double that. So if you look simply here is that the population in Canada has gone from 23 to 34 million, about a 50% increase. But the cost of delivering healthcare has gone up 3.5-fold. So we now spend in Canada around $150 billion per year on healthcare. Now, cardiovascular, we can't blame cardiovascular for all of that, but the trend is the same in our domain compared to other domains. We can do newer tests. We have better drugs, but they all come at a substantially, exponentially increasing cost. So this is what worries me. If you had to ask me what is the thing that worries me about our healthcare system and my job in Alberta Health Services, it's our sustainability. We've been used to getting a 9 or 10% increase in budget per year, and when the government became fiscally strapped and we had to cut back to a 2 or 3%, we're having a hard time making ends meet because we can do a lot of great things, but we're not very good at eliminating the things that don't make sense. So this was recognized in the US by the American Board of Internal Medicine and was then advocated in Canada, and it's a program called Choosing Wisely. The Canadian Cardiovascular Society has come onto this, and what a number of societies have done is said, what are the 5 things that you as a consumer should not have done or your physician should not order for you? Because we see this a lot. We have this premise that if we do more tests, if we get more information, that's providing better health care. My neighbor down the street had a CAT scan to look for such and such. Maybe I should get one of those too. Or they're on a brand new drug. I've been on the same boring drug for 20 years. Maybe I should be on a new drug. The new drug costs 3 times as much, but maybe it's time to change. And so we have been not good at looking at that. So the Choosing Wisely program is really just a wake-up call. It's not to ration healthcare. That's what we're not talking about here, is that there's going to be great discoveries and new things that are going to be expensive but really worthwhile to do. But the only way we're going to pay for that is to not do the things that aren't useful. So we really need to get out of the mindset of just adding one more new thing. Well, I had this test and this test, let's do another one. If the new test is better, then let's not do the first two tests at all. Or if this drug is better, let's not add it to the old drug that's there. So this is something that we think about a lot. And maybe when we talk about personalized medicine to identify heart attack risk is not, let's take a blood test, measure my genome, let's do a CAT scan to look at whether I have plaque anywhere in my body. Maybe it's a much simpler thing. Maybe we need to go back to basics about prevention. So the simplest thing for personalized medicine for cardiovascular care is something called the Framingham Risk Score. So every one of you in this audience that doesn't have established disease should know what your Framingham risk is. Your physician should do this, and you should be informed to want to ask what this is. Basically what it does is it takes a number of parameters that you can see up there, your age, and your blood pressure, and your cholesterol, and your good cholesterol, and whether you smoke or not, and whether you have diabetes, and it creates a risk score. So if I push myself in there, I come up with 8 points, and if I go over to the other side, that means that 8 points gives me a 10% or a 10-year risk of developing something bad of 6%. Not bad, 0.6% per year. That's deemed to be low risk. More than 20% is high risk, and we use that kind of information to determine whether you should be on cholesterol-lowering medicines or blood pressure-lowering medicines, etc. But I would suffice it to say, if I asked around the room how many of you know what your Framingham Risk Score is probably not all that many of you. So coronary atherosclerosis is this boiling pot of risk. It's blood pressure, it's cholesterol, it's being overweight and having diabetes. If you want to turn up the heat on it, you smoke cigarettes, and the risk becomes high. 90% of the population at some point in their life will have a cardiovascular risk factor that needs some identification. So this is where we're at with respect to looking at risk, and the Framingham Risk Score just kind of puts that in. It's not sexy, it's not high tech, but I would suffice it to say is that in the developing world is we would get fantastic bang for our dollar if we were able to apply that and treat the individuals who are at risk. And there's a lot of development of what they call the poly pill, where they put 3 or 4 pills all together, dole it out to people, and looking at whether that reduces risk or not. So if we think about what we need to do personally to lower our cardiovascular risk for atherosclerotic heart disease, it really comes down to knowing your numbers, know your Framingham risk, and your cholesterol, and your blood pressure, and what your body mass index is. And if you have a concern about blood sugar, then knowing that as well. If you're inclined to wear a pedometer, then know your step count as well. So when you go to see your family doctor or your primary care nurse that looks after you, this is something that we should be pushing for. Don't be pushing for the high-tech test unless you need it. Push for basics of prevention and risk that will help us a lot, and that may help us with sustainability. So if we come back to my original question in terms of where are the great advances going to occur, is it going to be in the high-tech arena of all of the things that we talked about, basic science approaches to understanding the mechanisms of disease? That's going to lead to some beautiful discoveries, pathways that we didn't know of before that will allow us to create better drugs and better therapeutics. Imaging is going to be important. But at the end of the day, it may be that the prevention aspect of things is going to be just as important, or some combination thereof. So our mission as researchers within the Faculty of Medicine is to push the envelope on science. It's to create new knowledge and teach the next generation of people that skill set as well. Our challenge as healthcare providers, which is a hat that I wear, is to pick out the good technology from the not, because we're always looking at what's the next and the greatest thing. It's more expensive. Sometimes it works out really well, and other times it doesn't, but we need to be responsible to do that. And finally, it's the responsibility of all of us here to understand our own cardiovascular risk, to be informed. And that's fantastic that you're here this evening getting informed about what the issues are in infection and inflammation and cardiovascular disease, and in the future, other things that this faculty does so well. We need to be informed to make those decisions. So whether it's going to be low-tech stuff or high-tech stuff over the next decade, I'm not really sure, but I'm really excited to find out, and I think the sky's the limit when we start talking about that. Thank you very much.